Good morning, and thank you for joining us today. My name is DuBois Bowman, and I'm the Dean of the University of Michigan School of Public Health.
And I'm Marshall Runge, Dean of the University of Michigan Medical School. Dean Bowman and I are honored to introduce a panel of experts from Michigan Medicine and Michigan Public Health to answer some of your most pressing questions about the COVID-19 vaccines, variants, and when we can expect to put this pandemic behind us.
The COVID-19 vaccines have brought with them hope for an end to this pandemic, but they've also brought many questions like which vaccine is best? Are all of the vaccines effective against the COVID-19 variants that are rapidly spreading? What can a person safely do once they're vaccinated? What percentage of the population needs to be vaccinated before we can safely get back to activities we once enjoyed?
Today, our colleagues will answer many of those questions and share their expertise based on decades of work and research on infectious disease. It's my pleasure to introduce our panelists. Dr. Sandro Cinti is a clinical professor of infectious diseases at Michigan Medicine and at the Ann Arbor VA Health System. His expertise includes HIV clinical research, infectious diseases, bioterrorism, and emerging infections. He has been a prominent subject matter expert during this pandemic and prior infectious disease outbreaks, such as Ebola and SARS. Dr. Cinti also co-chairs our COVID-19 vaccine task force. Dr. Laraine Washer is a clinical associate professor of infectious diseases at Michigan Medicine. Her areas of research include antimicrobial stewardship, infectious diseases, and infection control. Dr. Washer is one of our leading epidemiologists who guides our Department of Infection Prevention and Epidemiology, which has provided incredible support and expertise throughout the pandemic.
And joining Dr. Cinti and Dr. Washer on today's panel is Dr. Arnold Monto, a professor of epidemiology at the University of Michigan School of Public Health. Dr. Monto has served as acting chair of FDA's Vaccines and Related Biological Products Advisory Committee, or called VRBPAC, which has been advising the FDA on the authorization and licensure of the COVID-19 vaccines. Throughout his career, Dr. Monto has been involved in pandemic planning and emergency response to influenza and other respiratory outbreaks, including the 1968 Hong Kong influenza pandemic, avian influenza, SARS, MERS, and of course now the coronavirus pandemic. Today's panel moderator, Dr. Emily Martin, is an associate professor of epidemiology at Michigan Public Health. Dr. Martin leads CDC and NIH-funded studies of influenza vaccines in ambulatory care, hospital, and community settings. During the pandemic, she's been using COVID-19 public health data to help inform mitigation and policy at state and local levels. So with that, I'd like to get things started and turn it over to Dr. Martin.
Thank you, Dean Bowman. Thank you, Dean Runge, and thanks to everybody that's joining us live today. So many people, when they registered, submitted excellent, great, thought-provoking questions when registering, and we're going to be using those questions to guide our discussion today. We're lucky to have a really large number of attendees. It's great to see so many people looking to get more information about the vaccine and the current state of the pandemic. So we're not going to be taking questions through chat. We're going to be using our registration questions to guide the discussion today. So we're going to go ahead and launch right in and get right started. What I wanted to start with was a discussion, being here in Michigan. The topic of the day has been the state of the increase in the pandemic in Michigan, and particularly a lot of conversation around the new variants of SARS-CoV-2 that have been circulating. So I wanted to start our discussion today talking about what do we know about vaccination and about variants, and do we expect to see any changes, kind of how does that affect how we think about vaccination right now? And I think I'm going to start with Sandro, and we'll just sort of move around and kind of talk about how I'd like to hear how each of you are thinking about this right now.
Thanks, Emily, and welcome everybody. And it's great to be here with Arnold, Laraine, Emily, and everybody else. It's a good question. The current variant that's circulating quite widely at Michigan, and we're probably up above 50% now, is this B117, which came up in England initially, and it's more transmissible, and we're finding that it's probably causing more severe disease too. And I'm in the hospital right now and seeing younger people that haven't been vaccinated in the hospital. So that's very concerning. The vaccine should work fine against that strain, that variant. There's been no problems with the vaccine efficacy there. There are a few other strains that we can all talk about here, and I'll leave it open to Arnold and Laraine in a moment, but there's the strain, and you too, of course, Emily, because I know you've been looking at this, but there's a strain that started in Brazil called the P1, and then there's a South African strain called B1351. And those strains may have a little bit of reduced efficacy in terms of preventing symptoms. Now, a very important thing to remember when we're talking about vaccine is when they're talking about efficacy, and you look at efficacy, efficacy means people getting symptoms. But what you really want to see are people getting hospitalized, and are they dying? And probably both of these strains will still be protected from those two more severe possibilities. So there may be a little bit of decreased efficacy in terms of developing symptoms, but we should be okay with the current vaccines. And all of the vaccine providers, including Moderna, Pfizer, Janssen, are looking at for boosters in the future to look at these variants. So I'll leave it open. Arnold, Laraine.
Yeah, actually, I wanted Arnold, if you could comment to what, from your perspective, how does the FDA think about variants? Do you think the FDA is thinking about variants? Do you think that they will? How do you think about that?
Well, the FDA is thinking about variants. I think we got this discussed front and center when the Johnson & Johnson review was taking place. And this was because that review occurred most recently. The earlier reviews occurred in December when we really weren't worried about the variants. And in addition, the Johnson & Johnson vaccine was tested to a large extent in South Africa and a little bit less in Brazil, were two of the more worrisome variants because there is some degree of reduction in efficacy against those. But for the South African variant, there was a little reduction in efficacy, but as the FDA reviewer, and the FDA reviews these independently, the raw data, said the confidence intervals for those who know about statistics actually overlap. So while there was a reduction, it was slight enough so that they couldn't really say that it was a reduction. And most importantly, the severe disease, as Sandro pointed out, was almost eliminated. Nothing's going to be eliminated because there are always outliers, but we can be reassured that this is not only a safe vaccine, but a highly effective vaccine, more effective than we could have hoped for.
Great. I'd also like to add that we're getting information about real world efficacy. So Dr. Monto talked about the trials, but the real world efficacy, particularly against the B117 variant, is looking really, really, really good. The nation of Israel had done a mass vaccination campaign, and they're way ahead of much of the world in vaccinating their population. And they did this vaccination campaign at a time when 80% of their cases were the B117 variant. And they found excellent efficacy, about 94 to 95% efficacy using primarily the Pfizer vaccine against symptomatic disease, and nearly 100% efficacy against that severe disease or hospitalization. And so we don't have as much real world efficacy for some of the other variants, but I think that information will be coming and hopefully will be positive.
And one of the questions that we saw come through was a question about, can you still get infected after you get, do we still see infections? Do we still see hospitalizations after getting the vaccine? I think it might be a good opportunity to talk about what we mean when we're talking about vaccine effectiveness. I think Arnold and I have been doing influenza vaccine effectiveness for a long time, and we had The history of having to do this for a vaccine that comes out of trials at like 60% effectiveness or 70% effectiveness instead of being able to work with a 90%, 95% vaccine. The way we think about this is that you've got, out of the disease that normally would have happened, the vaccine is going to reduce that by whatever percentage the vaccine is effective. So it's a 90% effective vaccine. You're going to take the amount of disease that normally would have happened, and you're going to reduce that by 90%. Now, that sort of means different things based on how much disease is around in the community. If you've got a lot of disease, if you've got 1,000 infections that would have normally happened, that remaining 10%, the small percentage of infections that are left on the table, that number is going to be larger than if infections are kind of rare in the community at large. And so it still makes sense to try to drive down community rates while you're vaccinating as well, so that those few opportunities for breakthroughs become even more rare as we're vaccinating. Arnold, I don't know if you had anything you wanted to add about effectiveness there. I think that what kind of parallels with effectiveness is the question about, we're always looking for this balance between we want a vaccine to be as effective as possible and we want it to be as safe as possible as well. Arnold, could you say a little bit about safety and what the FDA was looking at and what kind of data we have available now for the vaccine safety profiles?
FDA typically looks at clinical trials, and their job is to evaluate for eventual licensure. Here we are getting emergency use authorization. And the only difference is the time frame. The emergency use authorization is given after no less than 2 months of follow-up from the time the doses were given. But they're looking at the same efficacy as would be required for full licensure. And I suspect we're going to be pretty soon getting into the point of full licensure, because some people have said, why aren't these vaccines fully licensed? Well, there was an emergency. We had vaccines that clearly work very well, and they needed to get out there. And are there going to be advisories before full licensure? We're not sure. I would doubt whether they're going to go to the labor of pulling us all together to approve a vaccine for full licensure when CDC and other groups have been following up the vaccine as much as they have. So we're getting real world data in the United States. We got them for healthcare workers and for other first line workers. And we see that the vaccine in our country is working as well as it did in the clinical trials. So I think we are one of the few things we were lucky with this virus is the vaccine works and works better than we could have hoped for. And it is already making a real dent in transmission in places like Israel, where they've got a small population. They've been able to vaccinate a large percent of the population, and they are basically opening up. And that's the message. We will be able, the surest path to being able to open up is getting vaccinated.
Yeah, I think one of the things that I'm really positive on is the VSafe program that CDC is doing. And so a lot of people who have been vaccinated, I know this happened when I was vaccinated, you get a sign up link to sign up for the program. And I still am getting texts periodically to check in on my symptoms and to check in on any adverse events or any kind of now longer term impacts from the vaccine that I might be noticing. And I think that is a level of safety monitoring that we've done, and having that be real time available to public health professionals to review and to monitor. I mean, that's above and beyond what we've ever been able to do with vaccines. That kind of level of monitoring and data and real-time knowledge it's really incredible. And even with that level of scrutiny, the vaccines are still holding up as being safe. Sandra, I know one of your roles has been in the vaccine rollout with Michigan Medicine has been in closely following safety data. What have you seen? What do you tell people when they ask you about safety?
These are very safe. They rival the safety of many of our other vaccines that everybody takes, including flu vaccine. You're going to get symptoms, and I tell people expect your arm's going to hurt because 80% of people do with the Moderna and the Pfizer, probably somewhat with Janssen also. Expect that some people may get fevers, but overall these are very, very safe. Questions come up all the time. With the mRNA vaccines particularly, this is genetic material. Is it going to change my genetics? The answer is no. It doesn't even get into the nucleus of the cell where things that cause changes, and it gets destroyed almost right away after it does its job, sending the message. So the answer to that is no. We're even saying that pregnant women who are high risk when they get COVID should be getting the ACOG says pregnant women should be getting the vaccine also. So we're really moving forward. Kids are going to probably be getting these vaccines. So they're very safe. There's a lot out there. And I think we can all have a discussion here about, looking at the data that goes to the CDC, where people will say somebody may get a vaccine and say a week later they die, but they were in a nursing home and they died of a heart attack or a stroke, but that may go into the system as being proximal to getting the vaccine. So we have to be very careful when we read news, when we read stories about people dying after getting the vaccine. I would open it up here. I know all of you have dealt with that question too.
Yeah, it's been a lot, Laraine.
Yeah, I guess my only other point is that the safety of the vaccine is really high, as Dr. Cinti and Dr. Martin and Dr. Monto have talked about. But on the flip side of that, we know that there are both short-term consequences of hospitalizations, mortality related to actually getting COVID infection, and even long-term complications that people who may not be as much at risk for severe disease, may deal with if they get COVID, such as long-term loss of taste or smell, some long COVID symptoms that people have been experiencing regarding headaches, fatigue, some difficulty with concentration or memory. And so, when we compare the risks of the severe risk of severe disease, hospitalization, deaths, and some of the long-term consequences of COVID infection with potential risks of vaccines, it's really, really in favor of getting the vaccine for everyone who is eligible, not just those who are at highest risk of disease.
Yeah, with flu vaccine, we think about this with the concept of what is the burden of disease we're averting. And even with the flu vaccine, that the numbers kind of vary from year to year, but we see enough hospitalizations averted every year to fill whole football stadiums, enough deaths averted, to fill some years enough deaths averted to fill football stadiums as well. And so the protective effect in preventing deaths is definitely kind of predominant in these situations.
Can I make one point about it? So flu vaccine is a very great point to make, because when you talk about efficacy, most years flu efficacy is not 95% or 70%. It's a little bit lower than that. And yet we do prevent deaths, as you said, football fields of death. And Emily and I have done a study looking at the hospitalizations of people who had flu and flu patients who were admitted and had influenza, and then comparing those who got vaccine and didn't get vaccine. So within the hospital, they do better. And furthermore, even in flu seasons where the flu vaccine didn't match up, they do better. So there is something about getting vaccinations, and we all accept that. And these vaccines are better.
So I think I'm going to pivot a little bit to talk about who's getting vaccinated right now. I am a mother of a 12-year-old who is not getting. So when we talk about post-vaccination behavior, I could talk a little bit about how I act, knowing I still have susceptible people in the house with me. But Arnold, how quickly are we going to start seeing vaccine? With your crystal ball, when are we going to start being able to vaccinate the under 16-year-olds? I mean, that's where we're seeing a lot of the cases in Michigan right now. It's the 10 to 19-year-olds that are driving a lot of the cases, a lot of variant infections in this age group. And we don't have the option of vaccinating them.
Well, I just want to remind people of the review of the Pfizer vaccine, the one that came along first. And Pfizer, as a company, decided, because they had a small number of children or young adults, 16 and 17 years old, in their trials, they requested approval down to 16 years of age. The pediatricians on our panel, being very conservative, said, we're not sure that this should be vaccinated, and they split on this in the 16 to 17-year-olds because we haven't seen sufficient data. Not remembering that 18 and 19-year-olds who were in the overall group, there was no problem in their minds. So we had a couple of people who voted no against emergency use authorization. And this, remember, this is back in December, when we didn't have a whole lot of information about how well the vaccine was working. We were really working with the preliminary information from the clinical trials. That's a long answer to say that it's going to take the conclusion of the trials in first the 12 and above year olds, and those are underway. And I am sure that we're not going to need to have an advisory for FDA to extend approval. It's unfortunate that we can't do it right away, because I have no doubt that it's going to work in these populations. There will be need to be more data in the younger children, and that's very clear. And there are trials that are going on in infants. So sooner or later, we're going to be able to vaccinate way down in age. But right now, this is another reason why everybody else should get vaccinated. Because if we in a household prevent the adults from getting infected, then the children will also be protected.
Quick question, Dr. Monto. Do you think that there will be at least one vaccine available for that 12 to 16 age group by the time school starts in the fall?
It looks like this is really crystal ball and using public information about where they are in the clinical trials. I would suspect yes, because they're probably going to use what are called bridging data. They won't really need to wait to see that there is real efficacy against disease. And that's hard when a lot of the participants are also careful people, and even in the placebo group don't get infected. And I think, yes, we will have, before school opens, I'm pretty sure we're going to have at least emergency use and maybe even licensure. I think the licensure is going to start rolling out in a couple of months.
Yeah, the data for Pfizer is already 2,600 kids, 12 to 15, and it looked good.
So in the meantime, before we have that extended approval, you're going to have a lot of households that look like my household, where for a long time I was the only one vaccinated in my household, as I'm sure you had a similar experience. And now we've got the adults are vaccinated in the household. We still have this unvaccinated 12-year-old running around. What
we turn things around.
I know, it's usually
we started with the kids not being likely to get infected or sick. And now we've got vaccinated adults who feel empowered, and now the kids are the ones who are not.
Yeah, and so it's interesting, that brings up this question of transmission. So we've been in this really, because the clinical trials measured protection against severe disease, moderate disease, hospitalization, death. It's not that it wasn't protective against lower level infections, it wasn't measured in the same way. And so I know there's been a lot of data coming out around this question of, does the vaccine prevent milder infection, asymptomatic infection, and thus prevent transmission in vaccinated people. What is your take on the new kind of what information is around right now? Laraine, I feel like Laraine thinks about transmission all the time in infection prevention, especially now that there's these variants that are extra transmissible.
Yeah, no, I mean, transmission is really the key thing when we're trying to stop the pandemic. And so the trials, as Emily stated, were really set to measure symptomatic infection, even if it was mild, as well as obviously the outcomes of severe disease, hospitalization, and death. But more recently, there have been additional information coming out from real world information, some from clinical trials that looks at outcomes, including asymptomatic infection. And actually, the data is looking really, really promising there. There was a study of, I think, 6 hospitals in 6 states that looked at healthcare workers, first responders, and some others who had been vaccinated and those who had not, and had them test every week to see if they had infection, whether it's symptomatic or asymptomatic with COVID. And those who were vaccinated had a 90% less chance of being infected. And so there was 90% efficacy of the vaccine, including for asymptomatic infection. And I believe the J&J vaccine studies have looked also at some asymptomatic infection as part of their clinical trials. And their prevention of asymptomatic infection parallels their prevention of symptomatic infection. So I think this is, this is evolving data, but it's very promising and it's really important as we think about preventing transmission.
Yeah, Sandro, Arnold, do you have anything to add as you think about what the vaccine prevents and how that is evolving?
Well, it's I've always been surprised at the extreme worry about asymptomatic infection, because in most of our vaccines, we really haven't been focused on that as much, but we have been reasonably confident that asymptomatic infection prevention would parallel symptomatic infection. Maybe there might be some escapes. There might be actual infections without transmission taking place to boost immunity, which is another issue. But I don't know that we need to worry and wait until some of the trials that Emily and I are involved in, looking at actual transmission, preventing transmission within households, let's say, to really assume and be fairly confident that we're going to see community level immunity here develop. And I prefer to use the term community level immunity rather than herd immunity, because when we think of herd immunity, we think of stopping measles totally. And I don't know that we'll ever be able to do that with this virus, but we want to see in nearly complete reduction in transmission in the community, which we can get to with vaccination and also natural infection. And I think we will be able to achieve that, but that doesn't mean it's going to go away completely. And we're still going to have to behave reasonably in trying to prevent any transmission that might be occurring out there. Not everybody's going to be vaccinated. There are still going to be infections taking place. And we really have to do the simple things like wearing masks whenever we know that there is community level transmission taking place. And that's why we're going to have to continue to monitor.
Yeah, I agree with you. Yeah, I think it's very, it's pretty clear that we should be focusing on getting people vaccinated, and that the people who are vaccinated aren't going to get the disease, and they're not going to transmit it. So that's the way we're going here, and I think the CDC, as Arnold mentioned, is going in that direction too, and all these studies are going in that direction.
At the same time, I would just have a word of caution, because I also think about behavior and transmission as well. And so it is still really important for people who are vaccinated who develop symptoms that could be consistent with COVID, fever, cough, difficulty breathing, or possibly other things like loss of taste or smell, to go ahead and get tested. Because as Dr. Martin talked about and others here, these vaccines are not 100% effective, and we do need to know about those who have breakthrough infection even after vaccination, because those who are symptomatic and have breakthrough infection after vaccination may still transmit to others.
Yeah.
They may have lower viral loads and they may have a less risk of doing that, but it is still a risk.
Yeah, and what Laraine said is very important for another reason. And that is, we expect these vaccines to prevent for a while, but we don't know what a while really means. And at some point, we are going to see waning of protection. And at that point, we really need to follow up, because we hope by that time we're going to have things like booster shots ready to go, which will also address the variants. But this is one area that's still unknown, and we need to keep our eye on the ball in terms of follow-up, longer term follow-up. And we hope this will not occur for a year or 2 years, but we're not sure. And follow-up in the vaccinated is very important.
So we got a lot of questions about the practical implications of this, and actually a lot of the questions I get are very like, especially when you're looking at right now, the situation we're at, where you've got a lot of households where some people are vaccinated and some people aren't vaccinated, do you go to a restaurant? Do you go to a movie theater? How has, I think this is an interesting, actually crowd to poll amongst ourselves. I think we're all in kind of slightly different situations, but we're all vaccinated. And so to kind of think about how, so in my family, we're still pretty conservative because, I've been the only person vaccinated in my household for a while now. And I have a child that's not going to be eligible to be vaccinated for quite some time. And she's going to, she's going to be going to school. She's got, she needs to interact with the community. So we tend to be pretty conservative in my house. We still do takeout. As soon as I got vaccinated, I became the official grocery store shopper. Arnold and I have talked for a while about how much I love grocery delivery. So that's going to stay for a while, but when we do need to go out, I tend to be the one that does. But you guys might be in a different position. Where are you in terms of your behavior?
So Emily, I'm kind of in your boat, I think. So I've been fully vaccinated for a while as a healthcare worker. My husband has been partially vaccinated. He's had 1 of 2 vaccines. My 17-year-old has been partially vaccinated, had 1 of 2 vaccines, and my 14-year-old is not eligible for vaccination. And so we too are still quite conservative, and I have not gone out to restaurants with my family. And I also think about the flip side of that is, a lot of our restaurant workers have not had the opportunity to be vaccinated. And so from my public health lens, I'm not ready to do that. It's not that someone whose whole household is fully vaccinated shouldn't go out to a restaurant. I think they certainly can. But those who have partially vaccinated households may wish to be a bit more conservative in that regard. We talk about restaurants mostly because you can't wear your mask during that activity. I have, however, I was also doing a lot of grocery pickup, and I too am the grocery person for my home. And I actually love to go grocery shopping. And so I started to go back going grocery shopping, but I go at off times and I go quick. And I only go to places where I know people are going to be wearing their masks. I'm not interested in going to places where there's not good mask enforcement.
Right.
A lot of it, and I'm interested in Sandro and Arnold's perspective too. I like, a lot of this has to do, we still, in my house, we still watch community rates as well. When things are really high and going up frighteningly fast like they are right now in Michigan, we're definitely more conservative than when things are stable and low. Sandro, what have you been doing?
Well, because of all the charts that you and Marissa brought to our meetings and showed us that restaurants were the worst place to go, and bars, My wife is half immunized at this point, so we're not going to indoor restaurants. We have done outdoor restaurants when it's possible. We've done outdoor events with our friends, but distance. And we're still doing that for the moment. I think that once our kids are out of the house, but both my boys are about to get vaccinated. So I think it's safer to go, and indoor dining is still a bit provokes some anxiety, but I think it will be safe. But just because of the discussion we've had here, we're not transmitting it. We're not likely to get infected with it. One caveat here is when you have such high rates of infection as we do in the state right now, and we were talking about, 90% effective means if you were going to get 100 cases, you're going to get 10 cases of people who were vaccinated, if people were vaccinated. But if you have 1,000 cases, you're going to get 100. So there is still the possibility, and I think we want to see the numbers going down before, but that's where I stand at this point. I'm doing more, wearing my mask when I need to. My wife and I have gone shopping. I am a proponent of the exposure times time. So the longer you're in front of somebody or by somebody without a mask, the higher the risk. So a market is really low risk. Arnold, I want to hear what you have to say.
I want to know if Arnold's going to rock concert.
Well, being up there in age and being therefore in the most vulnerable group, and having the fortune of having a daughter and family who live in Ann Arbor, about 5 minutes away from us, we were, during the period before we could get vaccinated, basically hermits. We were not going out. We were staying in the house. And I think a lot of people in our age group were doing the same thing, which puts you at a lower level of expectation of what you need to survive, because you find, at least when at least two of us are together, and I'm not talking about when somebody is all by themselves, which is another real problem. Our expectations were pretty low. But what's happening now, we're having family gatherings, but only with people who are in the family who are vaccinated or at least on the way to full vaccination, because the rates do drop. And it, again, depends on what's going on in the community. And a lot of this was going on before we got into our higher rates again. But we weren't even eating together. We were eating at different tables. We were gathering together with masks during the time we just wanted to talk and socialize. So I think you just have to be reasonable. There are no good rules to follow. There are no rules to follow. There is only advice, and you just have to do sensible things and realize where transmission takes place. And I agree with Sandro, it's time plus closeness of exposure. So casual contact isn't going to do it, but being together with somebody in a bar or in a restaurant is where a lot of the transmission is taking place. And now even being together with some of the youth sports seems to be a place where transmission is taking place as people exert themselves. There's a lot of air hand transmission. I think we should remember this virus is transmitted through the air. It's hand hygiene is great, but without trying to stop with masks or whatever, air transmission, you're not going to control the spread of the virus.
Right.
Yeah. So, it really, we've mentioned the high rates a few times, and the predominant strategy for trying to bring that down right now in the US really seems to be vaccinate. It really seems to be vaccine first as our strategy, like the era we're going into. I'm interested, both Sandro and then Laraine, I'm interested to hear as clinicians, so the vaccination as a mitigation strategy is only as successful as people actually use the vaccine. And now we're in a place where, in Michigan, we have wide open eligibility. Nationally, eligibility is going to be opening across the country within the next couple of weeks everywhere. for everybody, but it only works if people use it. What kind of conversations are you having with people about hesitancy, and what are you, what are good tips for talking to people, especially, people who have family members or people close to them in their lives that want to have that conversation about vaccination? What strategies do you use?
Laraine, you go ahead.
Yes, I would love to start. Thank you, Sandro. So these are hard conversations. And the first thing is you really don't want to badger people and kind of bully them into changing their mind, because it just doesn't work. But really a couple of strategies that I think could be effective are, number one, trying to understand the reason for vaccine hesitancy.
Yeah.
And I can talk a little bit about that. And secondly, understanding what might motivate someone to become vaccinated, and trying to address those on a very individual basis. And so there are lots of reasons that people might have hesitancy over this vaccine. And maybe it's because they don't think it's going to work, or work 100%, and that's what they want. Or maybe it's they're concerned about safety. We've talked about those concerns here. Maybe it's a part of a broader vaccine hesitancy related to all vaccines, versus just a COVID. And that approach is going to have to be different and maybe harder to overcome. And maybe it's about just overall trust in medicine, or in now the government, because this is very much a national vaccine campaign. And depending upon what the hesitancy is centered around, the conversation should be very different around those things. So I think taking time to understand what the reason for hesitancy is important. And then on the flip side is really what would motivate someone to get vaccinated. And so I think that, certainly avoiding hospitalization or severe illness is a motivator for many people, but other people may not really feel that they're the one at risk. And so really talking about decreasing risk to others, that they might, that might be a higher risk that they're close to, or even if they're not close to, there may be, some motivation there for people. So I think it takes time to understand that the reasons for hesitancy and maybe a relationship, to be able to get people to become willing to get the vaccine.
Yeah, that's great, Laraine. That's exactly right. I think more of asking questions of a group as opposed to saying what we know, because then you really get at the root of it. When we started the vaccination efforts here at Michigan Medicine, my counterpart, my co-chair, Stan, and I did some talks for areas where we weren't getting a lot of information out to our environmental services staff, our transport staff, and those were really illuminating sessions. There were some people who you're never going to convince, and that's okay. I mean, there are people who will never get the vaccine, but there are other people with asking very specific questions, and then answering those questions to the best of our abilities will often help, and at least get them to think, maybe I do want to take this. What Laraine was saying, a lot of people don't realize that even though they're not at high risk, I'm just going to get a little illness, they could transmit it to their grandparents or their parents, and then those people could get very sick. And almost everybody, when I go into a situation, almost everybody I talk to had somebody in the family, somebody that they knew who died of COVID-19. Everybody has had the experience. And so drawing on that to say, you can prevent that. You can be part of the solution to prevent that, sometimes helps. I think one thing about hesitancy, we have to be a little careful. I think sometimes hesitancy was almost used as an excuse not to go into certain communities because they were obviously going to be hesitant. And we have to continue to really go out there and have talk. I just heard a story this morning about Detroit not having as high rates and having and equating that with hesitancy. And so is it hesitancy, or is that we're not just getting in there and getting the message out? So we have to continue to be better at that, I really think.
Yeah, I think that's a great point. When I think about this from a public health side, I mean, sometimes hesitancy is not true hesitancy, but it's like they don't want to spend an hour, somebody doesn't want to spend, or they don't have the ability to spend an hour on the internet searching for an appointment, and then get in a car that they may not have to drive 45 minutes to get a dose, right? It's on us to bring the vaccine to people and meet them where they're at. to get it. It's one thing to get somebody interested in the vaccines. The other thing is that, okay, now you have these 18 steps in this incredibly arduous process to go through to get it. I think it's getting better. I like a lot of the campaigns and the mobile vaccination efforts that are starting to happen right now. And I think that, you know, we and in the public health space have to commit to
It's been such a paradox. People who are driving long distances to get the vaccine over state lines, as a matter of fact, as we saw in some of our press just recently, and others who say, under no circumstances will I get this vaccine. It's too new, we don't really understand it. And I think we need to meet in the middle, and we need to realize that it's not just a duty for yourself to get vaccinated, but it is a duty to the community and not only your relatives, but the overall population to get vaccinated, because this is still a severe disease. As Laraine has pointed out, we don't want anybody, whoever they are, to get this disease, because in spite of everything, we treat it much better than we used to, but people are still dying of this disease, and we don't have a magic bullet for treating. There's work going on better therapeutics, but we're not there yet. And therefore, our best way to prevent deaths is to prevent illness. And that's what we have to do collectively. It's got to be an all hands on deck, trying to do this in the best way we know how. And for those who are convinced that the vaccine is working and is safe, as I think we all believe, to try to convince their friends, their neighbors, that we need to pursue the vaccine option as vaccine becomes more available. We won't have the excuse going forward that it's hard to get, because it won't be hard to get very soon.
Yeah, and I want to put a plug in for the state here. Our state has been really great in terms of using the social vulnerability index to try and get the word out. And I think the federal government has done it. I think we're late. We were late to doing that. We didn't do it early enough, but now we're on track. And so I think some of that we have to keep going though. And of course, some of that will work out.
So we've got about a couple of minutes left. I wanted to kind of turn to what comes next question. What is our post-vaccination? For Arnold, I'm going to start with you what's happening with the pandemic next? Like, as we get more and more vaccination, what is it going to look like?
Well, I always say that if anybody who predicts and says, I know, as some of our colleagues have said, I know for sure that we're going to see such and such. And is this a surge or is this not a surge that we're seeing right now? We really don't know, and we'll know retrospectively after we see what happens, what really did happen. But I think we're going to see, and this is largely hope as well, we're going to see the rates go down as weather improves. I think for a number of reasons, we believe, based on what we've done with some of the coronaviruses has just caused common colds, that they're mainly transmitted in the winter. We'll be out more. We're not going to be in as close contact. And I think that plus the increase in vaccination is going to give us a relatively quiet summer compared certainly to last summer. But that doesn't mean the virus transmission is going to go away. This virus is everywhere in the world, and it's going to come back. And we hope it will not come back in any in the way it's caused real impact on hospitalizations and the rest, but it's going to be there. And we're going to have to adapt our strategies to that situation. What exactly it's going to look like in terms of mask mandates and things like that, we can't say right now. And it's going to be dependent on how well we as a community respond, how well we get vaccinated. And the more that get vaccinated, the more likely it is we're going to be able to open up and see, well, let's say next Christmas, people being able to get together at a time when there is transmission, whether we'll be able to do what we want to do at that time. So it's up to us. It's a weird virus doing weird things and some predictable things like the variants. And we're going to have to tailor our responses to what the virus does. But we do have options for vaccination and the rest, and we can take some control of the situation.
Yeah, one of the things I feel really optimistic about on the, in the state, we've seen this really sharp downturn in both case rates and hospitalizations in people that are 65 and older, because we've hit those like 80 over 80% of people have gotten their first dose in some communities. And so we've gotten starting to get really, really high rates in groups, and we're seeing the effect of that already. And so I'm pretty optimistic about, as we move into midsummer, late summer. Sandro, Laraine, how do you think about what do you think post-pandemic looks like?
Well, my hopes, I'm with Arnold. It's my hopes more than my predictions, but I'm pretty sure I'm going to be able to see my kids. And I think I'll be able to play basketball again with my group of friends. So if I can achieve those two things, that's as close to normal as I need to get. But I think we're going to see a little bit more of congregations, people being able to get back together. So I agree with Arnold's assessment of that. I do think that once we decrease the numbers and the positivity rates are down about 3% or lower, you've mentioned this a lot, Emily, I think the variation rates will go down to the mutation rates, because coronaviruses in general don't even change as much as flu virus. So the reason it's changing is because there are so many cases. So that my hope is that also that we start to see a leveling off, that, Arnold said we may need to get boosters periodically, but maybe we won't have to change the vaccine that often. So that's.
So I think, when we talk about this pandemic, we have to remember that it's global. While we are making great progress with vaccines in the United States, and they're making some progress in the United Kingdom and some maybe lesser progress in Europe, there are huge pockets of the world where there's very, very little vaccine uptake, and yet the virus is there. And so, Dr. Monto talked about this virus not going away, and that's part of it. We can do everything in the United States, but we'll still have risks because we live, in a global society. But, for me, I think that the post-pandemic world will really be a time when we may learn to live with coronavirus or COVID, and it doesn't really mean bringing risk to zero, but bringing it to a level of risk that's very much like what we would accept with other types of respiratory viruses. So that we can do a lot of what we did in the past. And there may be a new normal, but a lot of the normal will be the old normal. So I hope that that's going to occur. I think we've learned a lot about ways that we can pivot. And I think a lot of those habits are going to persist, like our remote working and learning, perhaps telemedicine. And hopefully people are learning that they shouldn't really be going to visit other people or going to work or school when they're sick. That I hope is a big message of the pandemic. I think that there's been a lot of changes on how we design buildings and how we think about how people interact together, and some of those are going to stick. I wonder whether we're going to have vaccine passports or testing passports for a while to travel or go to events, and whether that's a good thing or not. But I do think that we're going to slowly and not all at once be able to go back to some of these larger gatherings. They just may look a little bit different.
Absolutely. I think you mentioned, Laraine, going to work when you're sick. Maybe that becomes, that's been one of my big soapboxes. Is one of the big lessons I think that we've learned is how poor of a job we were doing at taking care of people when they were sick before. in terms of like telling people to power through and show up at work. And we still have more to go, but I mean, there's a lot that we can do to break this habit. You make sure that people are supported when they're sick, have paid sick leave, have the ability so that people can stay home and recover quickly instead of be sick for 2 weeks longer because they're, you know, working a double shift when they don't need to be. And so absolutely. What other, any sort of other like lessons learned from the pandemic that you hope we carry into the future with our last, we got about a minute or two remaining that you know, things that we've built that you hope that will keep, that kind of last beyond the pandemic?
Well, I'm not sure we've totally done it, but the public health infrastructure and some of the strengthening of that, and I'll let Dr. Monto and Dr. Martin speak more about that, but it is clear that our public health infrastructure was not up to the task at the beginning and is getting there, right? So I'm curious what you have to say about that.
Oh, absolutely. And this is something we saw with 2009 and we've seen before too, is the tendency to build when we need it, but then ignore when we don't need it. So I hope that the investment continues so that we can keep, especially particularly around, I noticed most around testing, you know, this feeling that maybe testing's over. I think testing starts to serve another purpose. And some of these systems we've built, I think, make us safer going forward if we keep them, kind of keep them strong.
Yeah, maintenance of the public health infrastructure is a long-term problem. When you prevent something and you don't see it, you think that it's gone away permanently and you don't have to worry about it. And Sandro and I, a number of years ago, when the bioterrorism threat, when anthrax happened, all of a sudden the country realized that the public health infrastructure, the county health departments, et cetera, were totally underfunded and undermanned in terms of being able to respond. And we keep having these lessons and people keep forgetting. And let's hope that after this, we remember that community health is at the community level. And we've got to have good community health and state health departments in order to respond. And we just need to keep our eye on the ball in terms of keeping that message out there to our leadership.
So with that, I think I've brought us to the end of our time. Thank you to the panelists for a great discussion, an engaging, thoughtful discussion. Thank you for the attendees for all of the great questions. It made my job easy. And we're going to send out a follow-up email in the coming days with a link to the recording. You're welcome to share the link. Please feel free to send that around to anybody that's interested. Please go get vaccinated. And we are happy that you've spent the last hour with us today. So thank you and enjoy the rest of your day.